Dr. Watanga had her undergraduate studies at the University of Nairobi and later proceeded to Muhimbili University of Health and Allied Sciences in Tanzania for a postgraduate Master of Medicine in Clinical Oncology. She currently works in Kisumu, where she sees patients with cancer and practices in both public and private facilities. She also practices radiotherapy in Uasin Gishu County. Her presentation will take 30 minutes. So let us welcome Dr. Watanga. Dr. Watanga.
Thank you very much. My name is Dr. Watanga Laila, consultant clinical oncologist, Kisumu County. Like I said, I work in both Kisumu County and Uasin Gishu County. In Kisumu County, we work in both public and private. Private, we work also in Salama Cancer Center and other facilities also, and in the public hospital. My main presentation is on early and locally advanced cervical cancer. Basically, cancer arises from the mutation of normal cell gene. Mutated genes can cause cancer, are called oncogenes. It is thought that several mutations need to occur. So basically, one mutation does not lead you to having a malignancy. Cells that are old or not functioning properly, they usually destruct and you replace with new cells. Unfortunately, cancerous cells do not destruct like the normal cells do, like the RBCs after 120 days. These ones continue multiplying rapidly until they develop their own system of survival. We have a patient for cervical cancer. We want to give you an overview of what the kind of patients we see. Our children, she's HIV negative. She presented with a history of 4 months PV bleeding. There were dark red blood with actually clots that was on and off. She had a positive history of associated lower abdominal pain that was radiating to the back. Most of our patients present with history of associated foul-smelling vaginal watery discharge that sometimes can have color or not, but this one did not seem to have other than the smell. There's history of dyspareunia, but she had a negative history of postcoital bleeding. There was history of urinary frequency, but fortunately there was no history of urinary incontinence. So there was negative history of multiple partners or herbal use. She went to the nearest hospital, she was treated, nothing was forthcoming until she was later given a biopsy of the cervix. Our lady was a housewife, married. Sorry, there were 5 children, not 7. Our review of systems, it was unremarkable. She was stable, she had an echo of 2. Her pain on a scale of 10 was 5 to 10. She had mild pallor, there was no jaundice, no edema. Though she had left inguinal lymphadenopathies, they were fixed and matted and tender, around 2 centimeters in size. Her vitals were within normal. The other system, her abdomen was just mild tenderness, but there was no hepatosplenomegaly. Her RS respiratory system was within normal. The main area of focus when we did was the lower abdominal exam. The normal external genitalia, she had a cervical mass that was extending to the parametrium, 6 centimeters in size, that was bleeding upon touch and extending to the upper thigh of the vagina. Fortunately, by the time we came back, she had a histology of moderately differentiated invasive squamous cell carcinoma. We proceeded to do a CT scan, which showed a cervical mass of 3 by 6 with 5.9 centimeters in greatest dimension. She had a few pelvic nodes, which was 1.4 to 1.2 centimeters. She had no focal lesions in the liver, but she had a left-sided hydronephrosis. We proceeded to do the CT scan with the chest abdomen. We found there was no pleural effusion, no HeLa of mediastinal lymphadenopathy. CT scan of the chest showed no pleural effusion, no HeLa of mediastinal lymphadenopathy. There was no history of pulmonary metastasis. Our blood works, because for all our cervical cancer patients, we do CBCs, UECs, LFTs, and also HIV test if we find the patient had not done. Her WBCs were within normal, her HB was 8.2, slightly low, and her platelets were on the borderline of being low, but they were normal. The only significant factor which tallies with our With our hydronephrosis, she had a creatinine of 224 and her urea was elevated, but our liver function tests were within normal. Next slide. Allow us to start on cervical cancer. Globally, cervical cancer is the second most overall and most common in developing areas. In our area like Kisumu, most of our patients have cervical cancer because of our HIV data, though we still have other malignancies, but this one is pretty common. It is the third most common malignancy among women and seventh overall, but it is common, like we said, in East Africa and Middle Africa, maybe because of our economic activities. And it accounts for 12% of all new cases, and we have a high mortality of around 11.84% of all cancer deaths annually. Next slide. Higher cervical cancer is most common in our continent and countries due to the fact that due to lack of effective screening programs to detect and also treat pre-invasive stages. But I think for this one, we can defend ourselves. We say we are trying to get more screening for the facilities and for people around. So I think when we educate people now, we'll be able to do more screening. But I think as per now, there is screening for every postmenopausal woman who gives birth. The MCH has tried to put a screening. So we encourage all of you to encourage others to attend. And the most common histology we find is cervical cancer, which represents 90%, though adenocarcinoma presents 10%, approximately 8%, and there's a smaller percentage. Etiology in terms of cancer, we all know HPV because there's a campaign in which the government has been trying to vaccinate our young children concerning human papilloma virus. So HPV can be detected in 99.7% of cervical cancer. Usually the positive thing of cervical cancer, it takes 10 to 20 years for a precursor lesion caused by HPV to develop to invasive cancer. So that's why we still encourage screening on any issue that you think is a presenting complaint, or you just go screening because it is a requirement for your health. So the spectrum of HPV-related genital disease ranges from external genital warts to cervical dysplasia to malignancy. Next slide. Our HPV in risk factors, our most common one is 16, 18, 31, 33. You can see the rest. The other ones are low risk, but HPV 16 and 18 create around 70%, and the rest create a very small percentage, though HPV 6 and 11 are known to cause most genital warts. Next slide. Our risk factors is early onset of coital activity. We usually tell our young girls that they can wait. So the early onset of coital activity produces as risk factors. Multiple sexual partners, partially because of the exposure to HPV. Multiparity, also because of exposure. Tobacco use is also a risk factor. Tobacco use is also a risk factor. Uncircumcised male partners, purely because of the carrying of the human papilloma virus, HIV infection, which is common in our area and in our continent, and then human herpes simplex infection. Basically, the infection are just because they lower immunity. So you are bound to have all those things. For, like what we said, it takes some years before cervical cancer develops into a malignancy. So cervical cancer is defined by well-defined pre-malignant phases. You can have, most of them are suspected on cytological examination and confirmed by histology. So that's why whenever you have a cervical cancer, you are going to see, you're going to see that when you come to the oncologist, we usually say, kindly go back, you get for us a cervical biopsy. But upon histology, we have cervical cancer pre-malignant stages. CIN1, where you have mild dysplasia on the histology, CIN2 is moderate, CIN3 severe dysplasia, and then CIN3 is a pre-malignant, that can exist at any of these stages. If untreated, CIN2 or CIN3 can mostly progress to cervical cancer, especially if you have very low immunity, maybe predisposing you to HIV. All those can cause you symptoms. Pathology, you're going to see the pathologist is going to tell you there's diffuse growth or there's, yes, and microscopic, you'll find that there's infiltration. Macroscopic, then mostly they'll tell you, they must give you a diagnosis of squamous cell carcinoma or an adenocarcinoma or something else, whatever they are going to find. Next slide. Our mode of spread, there's something that we must realize. Whenever you come to the oncologist, after we have requested for a biopsy and we have a biopsy, we usually do CT scans. And our CT scans is because we are trying to see how far has this disease gone or where does it like going to, because every organ has a drainage and they drain to the lymph nodes, and also the spreading can either be laterally, anteriorly, posteriorly. Like for cervix, because being drained, the area you're going to find is a lymphatic, so paracervical lymph nodes, internal and external lymph nodes, presacral, obturator, para-aortics. When we're going to reach to the radiology part, we are going to tell you the importance of why we keep on doing the lymphatic spread, because when we treat a patient for cervical cancer, when you're doing radiotherapy, you also include the lymphatic spread. Then the blood-borne areas, the lung, the liver, and bones, help us in staging you whether you are palliative or you're for curative intent. Next slide. Symptoms and signs. After that, we might have intramenstrual bleeding. Most of our patients, after the signs and symptoms, you will ask about fortunately, if a patient comes to you, a referral with all those, he'll come with you to the histology, he'll come with you with slides, with the CT scan report. As a clinician or a doctor, please ask about intramenstrual bleeding, ask about the blood stain per vaginal bleeding, ask about spotting, ask about frank bleeding. We said some of our patients come with clots, but some others will tell you, daktari, kuna wakati inamwagika, and it comes continuously. Ask our ladies about postcoital bleeding, because this seems to be one of the signs that comes early, because we said there's also pre-invasive, precancerous and cancerous stage. Then, unfortunately, as our ladies move on, sometimes the loss of urine and feces through the vagina. Sadly, sometimes when patients come to clinic, we get young ladies of around 27, 28 who have already urine or feces coming out of the vagina. So that one we already treat sometimes mostly as palliative cases. You'll find most of our ladies complain that I have pelvic pain or I have severe lower abdominal pain. So all these are signs that you need to ask your patient for, so that it can lead you to cervical cancer. Either if they come before the biopsy with these sessions, or if they come with the histology and the CT scan, when you're just doing your HPI, please throw it in so that the person next can know what to do. Next slide. Signs and symptoms. Most of our patients come with weight loss. We have talked about pervaginal bleeding. They're going to come with anemia. Fortunately for cervical cancer, there's a lot of blood transfusion and the fact that the HIV is also involved. Then when you have a chance to examine, you're going to find gross erosion of the cervix. There's an ulcer. Sometimes when you do the speculum, you're going to find a mass in the cervix, or sometimes up to the lower third of the vagina. Most of them are friable. That's why they report bleeding, and they can be cauliflower. Unfortunately, some of our masses are so large that they can extend all the way up to the rectum region, sometimes causing an erosion. And sometimes you can have a mass that is so large and disease extension that you're going to have a fistula from the vagina all the way up to the rectum. Next slide. We have talked about everything, but the most important thing, after you have done your clinical examination, you have taken your clinical history, you have done your workups, you have been brought for everything, histology, please check for CBC. The reason why we check for CBC is purely anemia. The reason we check for WBC is because of infection. The reason why we check for it is because most of our patients have either a blood picture that is not consistent. The UECs, the kidney function tests, are critical for us as oncologists for cervical cancer because you said hydronephrosis. Sometimes in some stages like stage 3B, you find that actually disease has progressed out and it is in the non-functioning, it is going to cause a non-functioning kidneys for one of our ladies. So that is important in the UECs, so that you can also collaborate also with the nephrologist and also the urologist in helping us putting a stent. Our liver function tests are critical because it helps us to see how the liver is working, because some of our drugs also clearance and also helps us in progression. And then please, a cervical biopsy, we said is compulsory. A chest x-ray and an ultrasound, if you don't have a CT scan, but these days we have moved, you can use them as your baseline in case you find you're in a facility which doesn't have, as you refer upwards. In the bigger facilities, we insist a chest, abdomen, pelvis, and an MRI of the pelvis, basically for staging. MRI of the pelvis is going to show us the soft tissue and show us what level of invasion it is. So it helps us and guide us even when we are treating, we know, and we can also use it next time in future just for follow-up. Cystoscopy and proctoscopy in case if you have a bulky tumor like most of our patients have, to check invasion of the bladder and the colon if you can afford it, but because of financial issues, most of the time we're not able to reach a proctoscopy. For cervical cancer, there's clinical staging, and then after clinical staging, there's also imaging. Stage 1 is basically when you have cervical cancer confined to the cervix. Stage 1A, we are rarely going to see it unless maybe a patient has presented with those symptoms, post-coital bleeding, all those symptoms. So we are going to tell you, okay, my dear, now let us take you for a biopsy. So it is only the pathologist that has the privilege of seeing stage 1A. Stage 1A1, we say is less than 3 millimeters in diameter, and then width is less than 7. Stage 1A2 is invasion more than 3 millimeters, but less than 5 millimeters. Unfortunately, we never get to see some of these malignancies with our eye, so our pathologists help us. Then we have stage 1B, which is all others and any visible malignancy from 4 centimeters and above. So anything less than 4 centimeters, it says 1B1. 1B2 basically is more than 4 centimeters. Stage 2 has moved out and extended to other structures. We said like our patient presented with the upper third of the vagina. We say some of our patients come with lower third of the vagina. Some of our patients, whenever you start opening, you're going to see you can't put the speculum because of the mass in the vagina. So if a patient comes to you and there is also spread into the upper third of the vagina, 2A, and if it's spread laterally, what we call the parametrium wall and the lateral side, we say that is stage 2B. In stage 3, it's more extensive, though you see sometimes it moves out of the pelvis, like stage 3A, when you do a speculum, you're going to find the mass in the lower part of the vagina, though it is more friable. So you're going to see it. And 3B is what we said, if you do an ultrasound and maybe you did not have a CT scan or you want to move it up, you're going to see it extension into the obstructive ureters, or sometimes they have with hydronephrosis or an unfunctioning kidney. So all these are basically clinical examinations that you can make either using a speculum, using bimanual clinical exam, or you can use even blood tests. Stage 4A is the one that extended to the rectum and the bladder. The rectum and the bladder, like we told you, some of our patients come with the disease and they tell you, I'm having feces or urine in the vagina. So those ones are stage 4A. And then for the sake of your CT scan, we have stage 4B, which actually helps you when you are doing the metastatic workup. So this one tells us our patient is in stage 4A, either there's lung, there's liver, or there's bone metastasis, or it has moved past basically past the abdomen, and then you can treat your case as palliative. Next patient, next slide, sorry. We said we use clinical judgment, but these days technology has been around. So we use MRI for pelvis, we use chest, CT, abdomen. Mostly our stage 1, we said is small, not visible. It is visible on MRI slightly, though we still treat it the same, but our stage 2 is what we are happy with, because with that we are able to see stage 2A. Invasion is limited to the 2/3 of the vaginal wall without perimetrial involvement. And then our perimetrial involvement is where you see the sides. Actually, you're supposed to assess it clinically when you're doing a vaginal exam. And then stage 3 is the one invasion of the lower third of the vagina. You are going to have a look at it, but you find the disease is not gone outside the pelvic wall. So this one you can see on speculum. Stage 3B, you are going to get it through your either imaging or your blood test, where you're going to see elevated urea and creatinine. So you can either clinically state at 3B before you move up to a bigger facility. These days with CT scan and MRI, we are able to do para-aortic lymph nodes. So for us oncologists, we're able to scale up to stage 3C using imaging. We said in stage 4, we have extension is beyond the true pelvis. And this is where you find patients that have disease either in the rectum or the bladder. And we say stage 4B is where you say disease has spread outside. So whatever you do, please make sure you have imaging. If you can do an MRI of the pelvis, the better, because you're going to get better soft tissue. Then the pathologist will, then the radiologist will be able to kind of give you all this information. Then as an oncologist or the person treating, you can stage the patient, advise, so that patients get proper information. Next slide. Influencing factors for each case is treated individually, the stage of the disease, using the CT scans, the MRIs, the blood works, the liver, and the kidneys. You must stage the disease. Influencing factors, the size of the tumor, because when you stage the disease, it determines the treatment you are giving. You either have to inform the patient, are we giving you curative treatment to treat your cervical cancer? Are we going to give for you surgery so that we can remove it completely? And is surgery not possible, so we are going for chemoradiotherapy? Is chemoradiotherapy not possible, so we are going to treat you with palliative chemotherapy so that we can contain the disease? The size of the tumor also determines the state, the modality of treatment. Like we told you, more than a certain centimeter surgery is not an option for a patient, because most of the patients, the first thing they ask you, Daktari, can this thing not just be removed plus my uterus? So we are going to walk through about those sizes of the tumors. The age of the patient, of course, take into consideration. Cervical cancer is something that takes very long. Unfortunately, some of our patients are very old, so you cannot treat them like the same way you treat a younger person. So you either have to decide what modality of treatment you are doing. Fertility desires, this happens if you have young ladies who have cervical cancer. Unfortunately, we have ladies of 25, 26, 23 who have cervical cancer. And if you do a hysterectomy or if you treat with chemoradiotherapy without appropriate modalities, you are going to have patients who are never going to be able to give birth. So that is one thing you have to explain for them so that they don't say, Daktari, after being cured, how comes I cannot have children? So you have to go through those stages of them. Then comorbidities, influencing factors. We said HIV is a nightmare. So you have to make sure that these patients can control their viral load and are taking their medication. These days, there's a lot of sedentary diseases like diabetes. If you have uncontrolled diabetes, you cannot be properly treated because of the treatment modalities available, though the doctors will try. And hypertension, we encourage their patients to do consistent follow-up for all comorbidities so that they can be able to get a better outcome. Next slide. Stage-based treatment, we say influencing factors, stage 1A1, that is basically microscopic and have seen by the pathologist, is treated by vaginal hysterectomy or excisional cone biopsy. Stage 1A2 and 1B1, which is 4 centimeters, is treated by radical hysterectomy and bilateral pelvic lymphadenopathy. In this stage, you must inform the patient about the issue of fertility, because if you do a radical hysterectomy and bilateral pelvic lymphadenopathy, the chances of delivery are reduced to minimal because she doesn't have a uterus to hold the child. So tumors less than 2 centimeters, and the patient insists that they still want to be fertile, radical vaginal trachelectomy, which is removal of the cervix, the upper part of the vagina, and parametrial tissues, and laparoscopic pelvic lymphadenopathy can be done for a patient. But if you have a patient who has already finished the delivery, then we are more radical in form of their treatment. Next slide. Stage 1B, 2, and 4A, anything above 4 centimeters, keeping in mind that we only don't treat according to stage, you are going to put the other things in mind. If all things are constant and it's 4 centimeters and has a deep stromal invasion tissue and there is an increased spread of parametrial and lymph node, surgery can be performed in selected patients, but unfortunately, we still have to follow it with chemoradiotherapy. So primary radical radiotherapy is preferred for stage 2, 1B, 2, and 4A. So anything above 4 centimeters, we usually prefer you just come for chemoradio so that we can give you more of curative treatment. Though if the patient opts for, or if they were seen by a gynec before they saw us, they can get surgery, then they come to visit us for post-op radiotherapy. Next slide. Though their outcome is usually much poorer than the normal ones. If surgery was done, the pathologist will look at residual microscopic disease. For each surgery, there is a histology. We talk about positive surgical margins. The pathologist is going to tell us about parametrial involvement. We are going to take positive lymph nodes in case you had a laparoscopic or something was done and you were able to remove lymph nodes. Then concurrent chemo-RT improves local control, survival rates compared as post-op radiotherapy alone. Remember, if you combine surgery, chemotherapy, and radiotherapy, there is high chance of our patients having higher morbidities. So with early screening, proper staging, proper imaging, you can quickly push the patient to the type of modality they are treated instead of trying surgery if it is not acceptable, and then you move up with all this possible. So your clinical judgment and radiological assessment will help you to make a decision. Next slide. Local regionally advanced disease, we usually treat it with external beam radiotherapy and brachytherapy. This one, we usually use it so that to maximize the dose to the tumor and we avoid normal tissues. We are going to discuss that aspect when we reach radiotherapy, where we are going to show you how when we are planning for radiotherapy, we also contour. When we say contour, I mean we draw around the disease, and then we also try to take care of your normal structures. So like your bladder, your rectum, your spinal cord, your bowels, those are things that we put into consideration whenever we are treating all patients with external beam radiotherapy. Brachytherapy is intracavitary radiotherapy, so that whatever has not been completed outside, we try to use brachytherapy so that we can treat the remaining part of cervical cancer. The 5-year cervical rates are very good when we deal with the radiotherapy and chemo. We have 2B, we can go up to 75%, 3B up to 50%. We say 50% because remember 3B, there was also the issue of non-functioning kidney. So depending on the time you came. 4A, we have a 5-year survival rates of around 20%. Remember, those are the people who have extension of disease into the bladder and the rectum. Yes. And then where we have a vesicovaginal or a rectovaginal fistula, like you're going to see sometimes in clinic, please send the patient for urinary diversion or a colostomy. And then after that, we are going to treat the patient as palliative. And we can do either radiotherapy to control what you need to control, as palliative dose as we proceed with chemo, but of course with proper psychosocial counseling. Next slide. We have talked about chemoradiotherapy. The purpose of the chemo is basically during radiotherapy to make the radiotherapy more sensitive. So we call it a radiosensitizer, but radiotherapy plays a major role in management of cervical cancer. We must give you high dose of 75 to 80 grays combined so that we can get some form of curative rate for you and give you a 5-year overall survival for our patient. So we have 3D conformal radiotherapy, we have IMRT, and then we have 2D, which we are no longer using unless we need to palliatively treat you. But these days we are moving to more conformal treatment where we draw around the illness, we put what do you call it, beams, or let's say X-ray beams around you to be treated, so that we treat only the tumor and we avoid treating of normal structure. So these days technology has improved. Next slide. Combined modality, we said, improves our survival rates. External beam radiotherapy is what we use when we are treating the whole pelvis. You'll see when our patients are on the bed, we tell them, the patients, we tell you I was being treated in the pelvis area. So we are going to include the uterus, the cervix, or in the case of post-operative cases in the early, we are going to treat the tumor bed. We treat the vagina, depending on how clinically you staged it free, and also how we stage it again when the patient comes to us. We treat the parametrial tissues sideways. We treat the pelvic lymph nodes. That's why you're telling you sometimes an MRI pelvis or a proper CT scan helps us in also contouring to draw, and we treat those lymph nodes so that the patient doesn't have it. And unfortunately, if you have para-aortic lymph nodes, they are also supposed to be included in the field, whether with a separate field or a whole large field. Brachytherapy is what we call intracavitary radiotherapy. We integrate it so that we can have maximum dose to treat cervical cancer. With this in brachytherapy, what we do is we take a radioactive source and we put the patient in lithotomy position, and we identify the cervix, and we use some equipment so that we treat the remaining part of cervical cancer that was remaining. That way we have better overall survival and better 5-year treatment response for patients who we have done external beam radiotherapy, where we have treated the whole pelvis and the areas that are needed according to lymph nodes, and where we have also integrated brachytherapy, and then the patients who we have also instituted the chemotherapy, which is once in a week when we are doing external beam radiotherapy. By the time we start brachytherapy, we usually don't do chemo again. Next slide. Whenever we come to treat you, we use external beam. That basically means we are going to position you on the bed. Usually we put our patients lying supine. In prone position, we can use a belly board. We are going to show you. That is in case a patient has a very large abdomen. But the purpose why we use the supine position is because we want the patient to be most comfortable. It has to be reproduced each time we are treating. We have to treat you in the same position all the time. We cannot afford to change it, because we're actually giving you radiotherapy and the aim is to treat the tumor. We put for you immobilization devices, we position and we keep in one place so that we stabilize your pelvis. And then we don't keep you to lean on a bed alone. We actually put immobilization devices to help our patients stay in one position during treatment. Next slide. Like whatever we have said, our aim with 3D conformal is the CT scan and the MRI are actually good indicators, because they actually show us to how far the disease has gone. So our aim is to better local control and survival. And also, on the other hand, it also shows us the other organs that are at risk so that we try to maintain them. On the other hand, it also requires sometimes very large risks, though we also, our aim is to make sure we take care of your normal organs. Next one. Steps to external beam radiotherapy, patient positioning and mobilization. After we have that, we are going to take information. We are going to take a CT scan. We are going to take you to treatment planning system, where we are going to draw around the tumor. And then we are going to plan. In our planning, we say we are taking X-ray beams or radiotherapy beams to treat the tumor. Then the oncologist is supposed to look at the other dose distribution, dose to the cervix, dose to the lymph nodes, dose to the other organs at risk. And then we also prescribe treatment on that day, and then we deliver. Then remember, for each time we treat you, we usually do quality assurance and quality control measures so that we ensure that we are treating all our patients in the right location. When we said we are supposed to put you in one position, this is what we mean. We make you comfortable in that when you lie on your back, we said supine. We give you a head support so that your head does not lie on the board. We give you knee rest. You see where you keep your knee so that we stabilize your pelvis, and we give you a foot rest so that your legs are not hanging. So, and also we make sure you don't have time to keep on rotating your pelvis throughout the whole treatment. Next. So those are part of our immobilization devices that we usually have in all radiotherapy facilities. Next slide. We said why we are going to treat you in that manner to make you comfortable, reproducible, and when we say affordable, we mean the items are reusable. So we keep on using them for different type of patients. We don't keep in making them, and then so that we can achieve better treatment for ourselves. Next. This is part of our immobilization devices. Some people use a backlog and others can use a knee and foot rest for our second patient. You see, depending on the facility you are in or how the patient is, or if the patient cannot lie, cannot fold the knees, you find we have very elderly patients or somebody has other comorbidities that it is not possible. So we can create for you a backlog or a neural leg positioner. Yes. Next slide. After we have done that, we usually are going to have given the patient contrast. There's something we told you in which we are going to continue, in which we take care of your organs at risk, like the bladder and the rectum. And then for CT scan, we don't do the whole body. We take from a T10, T11 up to the upper third of the femur. That is what we take, assuming that by the time you came to see for radiotherapy, you have slides you have done for a pre-diagnostic workup. So we know we are only treating the cervix. And then each facility has a bladder protocol. Sometimes some people have a full bladder and an empty bladder protocol. So depending on the facility that they all have their protocols. Then those images are referred to the treatment planning area system, which after that, you call the oncologist and the dosimetrist and the physicists, we contour and we start planning treatment. Next slide. Next slide. When we say contouring, you remember we talked about the cervix, the uterus, the vagina, the parametrial, and the lymph nodes. So we have like clinical treatment volume 1, clinical treatment volume 2, clinical treatment volume 3. This is universal for all of us wherever we go. So it's a language that we use amongst ourselves clinicians to know what we are doing. So when we say CTV1, we are treating the gross volume. That is where when you see, that is what you're going to examine. And also it includes the uterus and also a bit of the vaginal curve. CTV2 is below, extends 2 centimeters, most inferior of the vaginal disease. CTV3 is what we said, we like the MRI and the CT scan because they guide us in which lymph nodes. And then remember, CTV3 does not extend into the bowel, the bone, or the muscle. So basically it is the gross disease, whatever you see, a bit of invisible disease, maybe uterus extension and the lymph nodes that you're going to see. And then maybe if there was surgical clips, you're going to include them in CTV3. Next slide. That one is important for us because you remember saying when we do the MRI of the CT scan, that the CTV3, the upper borders is what like aortic bifurcation. That one will guide the radiation oncologist to know up to where we are being treated. And if there are presacral nodes involved, that when you're going to see the radiologist is going to give you an idea. If you have external iliac nodes, we contour around that area. And then we talked about the distal lower third of the vagina. If you have a patient who has it on clinical, in the radiotherapy, we prophylactically include the inguinal lymph nodes. Next slide. We said para-aortic field radiation can either be an extended field or can be a separate field. And that one we are going to use appropriate gapping. Next slide. extension of the field that is still extended. So you can either use a separate because of the side effects that the patient is going to get. The dose is about 45 grays, which is a bit too high. So most patients will have features of diarrhea, all those symptoms. So you can either decide to treat it extended or you treat it as separate. Next slide. This is what our borders call. This is our field borders. This is what, when you go to the treatment planning department, if you have an opportunity to see, we have a superior border. That is the upper margin of what we are going to use. So at L4, L5 of the lumbar, that is where our external and internal ilia occur. And then our inferior border is using the obturator foramen, and our lateral borders is 1.5 to 2 centimeters, the widest margin of the pelvic brim. We use this so that it can guide us to tell us that we have actually treated what is needed to be treated for that level of cervical cancer. Have we done at the proper area where we have included all the lymph nodes? And have we gone up to the inferior border where the disease is? And have we gone laterally so that we have covered all the lymph nodes that were involved? Because unfortunately, if you treat a patient halfway, you treat the cervix and you don't treat the lymph nodes, you're going to have disease spread. Next slide. And then also we also look at disease from lateral borders, because it is also going to show you the presacral lymph nodes. And so that is very important for us when we're making a decision. So anterior posterior, AP means anterior posterior, PA means posterior anterior, and lateral fields means on the lateral side. So we look at all those things when we make a decision for the patient during radiotherapy. Next slide. Our techniques are usually 2-field and 4-field. The reason why these days we do more 4-field, because we can have better dose distribution, and we can also treat, we say the cervical cancer moves sideways, so the parametrium, and then the skin reaction is decreased, and there's more treatment plan, but we have a better outcome. So initially we'd use 2-field, but currently most of us use a 4-field technique. Next slide. You usually will see that the radiologist has, the radiation oncologist, after we have staged the disease, when you bring them to us, we usually write a prescription, a radiotherapy prescription. So sometimes we can go 45 grays, we'll tell you in 25 fractions. And then, like we said, we must have brachytherapy, which is intracavitary radiotherapy. So we stage 1B, 1 to 2A, we go 45 grays, 25 fractions. When we say 25 fractions, we mean from Monday to Friday. All patients rest on Saturday and Sunday, and we give chemotherapy once a week, depending on the blood tests and the CBCs and the UVCs. Stage 2B and above, which is most of our illnesses we get, we can treat you up to 28 days, with which we are going to achieve 50.4 fractions, and then we include our brachytherapy. And adjuvant radiotherapy, like we said, fortunately or unfortunately, there are some patients who go through surgery before they come to meet us. We also look at the histology report. What has the pathologist said? What did they find? What were the margins of the tumor? Was there parametrial involvement? Were the surgical margins positive? Were the lymph nodes, if surgery was done, also positive? And then we make a decision, and then we treat appropriately. Next slide. Para-aortic radiotherapy, in case you do the CT scans and you find extension, you find the oncologist is going to do up to the para-aortic, whether separate or different fields. Then we said palliative treatment. All our patients have to be treated, whether you're treating them for curative or palliative intent. Palliative intent means, is there bleeding? Has the disease gone outside the pelvis? The true pelvis, has it gone beyond? Is it in the bone? Is it in the lungs? Is it in the liver? Sometimes you find our ladies presenting with severe pervaginal bleeding. So sometimes to control and severe pain, you can see the oncologist is going to treat the patient for either 5 to 10 days so that they can try to manage. But palliative means we're just trying to manage the symptoms so that we can improve quality of life. Next slide. IMRT is what we have mostly, and you'll find it's the new modality of treatment. It is better for us because it is also computerized. It also gives us a chance to put more beams on the patient. it gives us a chance because we can plan better and we can control. So sometimes if you don't have 3D, most facilities are moving to IMRT, others are moving to VMAT. Next slide. This is what shows you essentially what we are doing. Like you can see, we have spine, we have local lymph nodes, and then we can have a chance to see your organs like the colon, and we can see how much dose are we giving to that area. We can also see your, when we draw, all those pictures you're seeing, all those drawings are what we call contouring. So we will look for the organ and we will draw, like for the cervix, we'll put a CTV1 and see where the gross disease is. We'll go up to CTV3 where we have the lymph nodes. Then we are going to start drawing around your normal organs so that when we are doing radiotherapy, we keep into consideration that we are treating your tumor, the cancer, but we're also trying to take care of your other organs. And we also look at a certain level so that from a level of T10, T11, and we also have a chance to look at your para-aortic lymph nodes. Are they involved? So when you come back to the radiation oncologist, or when you're doing radiotherapy, we are usually going to do a pre-planning CT scan, which we have a look and we compare, is what we found on the diagnostic CT scan tallying to this one. Then we start drawing around the disease and the organs, and then we put our beams, and then we start treating you with radiotherapy. Next slide. Everything has side effects, everything has progression, unless we can manage to give cure. Sometimes our patients come with renal failure because of our disease, especially in 3B, but we always say, or hydronephrosis. You are supposed to, oncologist multidisciplinary, so you're supposed to work with the nephrologist, the urologist to help you put a nephrostomy tube. Most of it is acute. Lot. By the time they're coming to you, they'll say, I'm having vaginal bleeding or postcoital, or it comes out in clots. So that is our treatment complications. Even when it is being treated, sometimes we have it, or just as a progression, fistula and pyometria. Next slide. Treatment-related complications. After you have finished the presentation of the disease, whatever we treat you with, there are some patients who are bound to have side effects or treatment-related complications. But our main one, which we see due to radiotherapy, is colitis. We see a lot of patients with diarrhea. Sometimes we have an unhealing ulcerative. Sometimes our patients have pancytopenia. Pancytopenia means reduced white cell count because of either the radiotherapy when we're treating the areas, or basically due to the continuous chemos and the HP keeps on going down. Reduced bladder volume, intestinal obstruction can sometimes happen. One side effect of brachytherapy and radiotherapy, we have vaginal stenosis. So after treatment, we usually have a talk of when the patient is going to go back to sexual activities, or something that can be used so that the patient can maintain, can avoid vaginal stenosis for the purpose of continuous examination. Then sometimes as a side effects, if the radiotherapy was not planned properly, or a dose was given too high, or the positioning was not done properly, or packing, we find some of our patients present with a fistula. But fortunately these days, there are doctors who repair fistula, so you can still, fistula is not an option for not treating a patient. It is sorted and the patient is sent for either curative or palliative treatment, mostly palliative treatment. Next. Follow-up, after you finish the chemoradio and the surgery, you come back for follow-up. Sometimes we say we start at around 6 weeks. After that, we move to 3 months for 1 year, and then 4 months, and then 6 months. So basically, you're a patient for oncology up to 5 years, and after 5 years, we release you. But these days, we have chances of getting, in addition to CT scan, MRI pelvis, we also have PET scan, which can help us in diagnostic and follow-up. Next. Please remember what we talked about. Whatever you find, you must, if you find there is disease again, because when the patient comes for follow-up, please examine the cervix, look, is there any disease? Is there any regression from the size you saw? Remember to do complete blood works, clinical profile. a chest CT scan or a chest X-ray if you can't, and then make a decision whether you want to follow the patient closely or more aggressively, but usually they're going to be followed up at the oncology clinic. Next slide. Remember we said the CT scan, the image, the MRI, the PET scan, and we also request for biopsy in case if they have recurrent or persistent, and then if the result of what you find, then you usually manage the patient accordingly. Next slide. Our prognosis, we talked about it. Next slide. We believe in Africa we have, and in third world countries, due to HIV, we suffer the bulk of cervical cancer. So whatever happens, please, we encourage people to go for screening. It helps us in doing early cervical cancer screening treatment, which you have a more curative intent, and sometimes we're able to remove the disease, all of it, especially before we reach the cancerous stage. So if you go for screening, they will be able to detect, is it CN1, CN2, CN3, and treat you appropriately before you move to cervical cancer. Encourage all our clients to please do screening recommended. Anybody below 21 years, we are assuming they're not having sexual activity, so it is not, we don't recommend screening for them. Anybody above 21 to 29, cytology or a pap smear every 3 years. 30 to 65, HPV and cytology co-testing every 5 years. More than 65 years, if you have had adequate screening and if it is negative and you're not at a high risk group, then you do not need further screening from there. HPV is what we said is the most common of our risk factors. Though HPV testing is not easily available and there is lots to follow up, we still have VI and VI-Vila, so that as a primary screening modality. So even a patient said there was no HPV or there was no pap smear, kindly please, a VI and a VI-Vila is good enough for us so that we start from somewhere. Next. A pap smear is good enough if you're able to, if a patient is not eligible for it, then the pap smear, and it is a primary test to women mostly above 50, and we co-test even above 30. Most say 50 because they use VI-Vila, but anybody above a certain age can use it. And then we like co-testing with HPV so that our patients can do it if the resource is not available, so that we can also tell you, do you have human papilloma virus 16 or 18 or any other, and actually is it high risk or low risk, and then on follow-up modalities. This is basically our final slide to give you a summary of what we do. We said early stage disease, we use surgery. Locally advanced, that is, we use chemoradiotherapy. And when the patient has metastatic disease, that is disease outside the pelvis, like the lung, liver, bone, we do palliative radiotherapy and we just do chemotherapy. Next slide. Summary, cervical cancer is one of the most common cancers in females, especially in our area. Management varies along with stage, comorbidities. So we have surgery or radiotherapy or chemotherapy. For early invasive disease, like what surgery is the main one. In more advanced disease, we combine radiotherapy and chemotherapy as the standard of care. And the decision is usually according to the other issues that you as a doctor takes into consideration. Next slide. Thank you. Any questions?
Wow. Thank you very much, Dr. Watanga, for the well-articulated and detailed presentation. I'm sure everyone has learned something new today and will utilize the information gained in their respective hospitals. Please note, as earlier stated, that the recordings and slides will be sent to your respective emails, and the presentation will also be available on our social platforms, i.e. YouTube. We will now allow 15 minutes of questions and answers. Kindly post any questions on the chat. Thank you very much. If anyone has any questions, as earlier stated, please feel free to post them on the chat, and the speaker, Dr. Watanga, will answer any of your questions. Thank you.
Can I also suggest that if there's anybody like an oncologist on the call who'd just like to make a comment, I can see Dr. Sang is here. If you want to say something, make a comment, it would be highly welcome.
Oh, thank you, Ken. And thank you, everyone. Thank you, Dr. Watanga, for an excellent presentation. That was a very concise discussion on cervical cancer, which continues to ravage women folk in this country. And trying to get it in the precancerous stage is a major hope. And of course, the screening and the HPV vaccine. In fact, I just sent a question on the chat about whether you have external beam radiotherapy and brachytherapy there in Kisumu. Thank you very much.
Currently, we don't have external beam radiotherapy or BRAC in Kisumu. We are only able to use it in Eldoret and Nairobi and Nakuru have. Thank you, somebody else, for the pap smear recommendation, which you said is below for a patient, but according to the guidelines, it is 50 to 60. Yes, that is according to the guidelines, but we say 30 because some of patients who can afford to pay for themselves usually insist that they have come for a pap smear, but the recommended guidelines is for somebody older, so that we said, please also use the available in your setup.
There's a question. I noted that one of the recommendations of pap smear is client below 30 years, but according to the current guidelines, recommends age 50 to 60, 50, 60 something. Kindly, can you clarify?
Oh, sorry, I was on mute. There's something about external beam radiotherapy also. It is currently not available in Kisumu, but we have it in Eldoret, Nakuru, and Nairobi. As we currently practice our radiotherapy at Eldoret Hospital, which is in Eldoret. Kisumu is building one. Number two is about the pap smears. Yes, it is recommended for patients between 50 to 60, but according to some patients who are like 30 to 50, some of them would recommend they want a pap smear and a HPV testing, but it is recommended for 50s and above. And a VI villa is what we use in most of our facilities because sometimes a pap smear we don't have.
There's a question asked by Lily Ann. Which screening method can we use for women of 65 years old and above?
We usually use pap smears for them because it is easier and we're able to kind of get everything for them. So we use a pap smear, but most of our patients who come to us, rarely do we get to see patients who come for screening. As oncologists, we get them when they have the cancer. So we're encouraging people to go for screening. So they either use a pap smear or they use a VI villa of what they have. But a pap smear is more recommended.
Okay. There's another one here by Rachel Cargo. Can you recommend someone of 25 years to get the HPV vaccine?
By the time you reach 25 years, we assume that you have history of sexual contact. So the study of whether you are going to benefit from a HPV if you're already sexually active is something that is debatable. So the government has recommended 9 to 14 years of age. Yes.
Can VIA really be done for women over 65 years?
We usually recommend a pap smear, but if you don't have a pap smear in the facility that you're in, because sometimes we usually go to the peripheral facilities where you find it is done in actually ANC network. Some of them have, that is what they have. So we recommend use what you have. And if you have a bigger facility, then a pap smear is better off. And then we're also recommending also women, like what we said, of childbearing age. And then anybody who is in the risk factor, please go for screening. Whether they have whatever they use, it's a point of starting. We can always upgrade, or they can upgrade and take you to a facility that has everything you need. But just use what you have. Our question answer to number 1, which one of the following is not a risk factor to cervical cancer? We said tobacco use is a risk factor. We said immunosuppression due to HIV/AIDS is a risk factor. And HPV, we said 16 and 18 is most of a risk factor. Those we have, others 31, 33. Diethylstilbestrol is a risk factor for vaginal CA, especially adenocarcinoma. So the answer is A. Number 2, which is the most common presentation of cervical cancer? Everybody seems to have got it right. Post-vaginal bleeding, postcoital bleeding, hematuria, that is correct. In number 3, a 32-year-old presents with stage 4B squamous cell carcinoma, which is the most preferred treatment. We said stage 4B is the disease that has moved outside to the lung, the liver, and the bones. Surgery with radical hysterectomy is not recommended for a patient with stage 4B. Pelvic radiation with chemosensitizer is not recommended because you're treating with palliative, and surgery is not recommended for anybody who is palliative. Remember, surgery we said was for only stage 1 and the early stages of disease, and then we don't recommend. So we use chemotherapy, can be either cisplatin, paclitaxel, or whichever regime the oncologist is going to choose. So stage 4B is basically palliative. Majority of cervical cancers worldwide is believed to be secondary infection to which strains of human papilloma? We said 16 and 18. Everybody seems to have gotten that one. For number 5, we request a small concern. We had eliminated, our answer was D, in treatment of cervical cancer, which of the statement is true? Surgery, we said for stage 1. Option B, we said chemotherapy alone has an important role in primary treatment. No, chemotherapy can be used in actually late treatment, and for curative intent, you must combine it with radiotherapy. Radiotherapy cannot be used alone in stage 2 and 2 to 4. You must combine. But chemoradiotherapy, for number 5, we made an omission. Chemoradiotherapy is used for curative intent in locally advanced stages. So for number 5, we eliminated locally advanced. Thank you very much.
Thank you very much, Dr. Otanga, for answering. We have now come to the end of the presentation. I'd like to thank you all for your participation and everyone who has took their time out to attend this session. Our next event is on Tuesday, August 30th, and the topic is metastatic cervical cancer. Thank you all. If you have any topics you'd like us to present in future, feel free to post these on the chat before you log off. You can also share these on our social media pages. Once again, these are our social media handles. These are our contacts.
All right. Can we just say a word, Robert?
Yes. Yes, please.
Thank you, everyone. On top of what Robert has said, now we have had, during the course of this session, we've had questions being asked, and there are some that we're not able to respond to. And so we are sharing Dr. Watanga's, with her permission, we are sharing Dr. Watanga's contacts, and that you can actually be able to reach out to her with any specific questions. I mean, I saw somebody saying that they have some pain in their pelvics. I think those now can be directed to Dr. Watanga directly. I hope that, Dr. that is okay, that they can actually reach you if they have any questions.
No problem. They can reach us on telephone or WhatsApp, our WhatsApp number, and also through Sister Helen Okello, who is our palliative oncology nurse. Thank you very much.
Right. So you can take a short, copy this, or just take a photo of the screen, and that will enable you to be able to reach Dr. Watanga. And Dr. Watanga has graciously accepted to take us through the next session, which you've been already advised about. And we really, really are thankful. This is one of our best attended sessions, and over 90%, of the people who joined are still here at the end. And Dr. Watanga, that really is a testimony to how engaging the presentation was. So we do thank you very much, Dr. And if there are any topics that you'd like us to address, just send those to us on the contract that have been given. And so I would then, Robert, maybe you can give the final word of thank you.
Thank you. I'd like to just say thank you again for everyone who has attended. And we look forward to seeing you come August 30th, where we'll be talking about metastatic cervical cancer. I wish to sincerely thank you for joining us, and we hope to see you again at future events. If I would like for you to unmute and clap and give a round of applause for Dr. Watanga for her wonderful, wonderful presentation.